So we left it the last day looking at the Singapore health system. So first of all, doing a sort of a comparison between Singapore and Ireland on a geographic, demographic and economic basis, and seeing some similarities and some differences, and then looking in more particular at the Singapore health system. And in its structure, it is quite similar to our own, having the three sectors, the public, the not-for-profit and the private or for-profit sector across all three, and then the public sector divided between a body involved in regulation and legislation and a body then involved in running the sort of day-to-day operations of the healthcare system. So the Ministry of Health is the equivalent of our Health Service Executive, and the Department of Health is the equivalent of our Department of Health. And then the rest of the sectors are largely synonymous to what we have ourselves. When looking at the Singapore system, like what strategies do they adopt when looking at running the system? One of the big differences is the creation of incentives for responsible behaviour and efficient delivery of services. So they're looking at incentives on both sides, not only on the providers, but also on the consumers, the patient side. The creation of incentives of both. In the society itself, there's a strong promotion of personal responsibility. The first port of call is always the individual. That it's somebody else's problem. That it's not somebody else must fix it. It's not somebody else must provide it. There is state supports, but the first port of call is personal, family and community responsibility. That you build it from the bottom up rather than from the top down. There's a discouragement of overconsumption through cost sharing. So all decisions that are made involve a certain degree of cost sharing. That if you want more, you must pay for it. Not paying the full price, and the subsidies are also related to income. So if you're on a lower income, the subsidy is far higher. If you're on a higher income, the subsidy is lower. But there is sort of this incentive to get people to consider the costs. That it's not just all benefits. There's regulation of hospitals, doctors, and the use of high-cost medical technology. So while there is very much a private element to the market, it's not completely unregulated. But the costs, the charges, and the technology that can be used is controlled centrally. And then there's competition. The patient gets to choose where they want to go. The patient has to pay regardless of where they want to go. If they go to the public or the private, there is cost sharing involved. There is money that has to be paid. But it's up to the patient to decide. It's not a doctor or an official or a bureaucrat deciding. It's up to the individual themselves choosing where they wish to go to. So when looking at where the financing comes from, one is the first starting point is to instill personal and family responsibility. This idea of cost sharing. We have some elements of it in Ireland. One that got in the news during the week is the prescription charge for medical card holders. That every time they go to collect an item that's basically free under the medical card, they have to pay a prescription charge of 50 cents per item. So previously this was free, and there was the belief or the suggestion that there was overconsumption, that people were just taking the medicine without actually really needing it. And even a 50-cent charge would get them to weigh up the costs and the benefits. There's the ensuring of future sustainability through savings. So it's all based, or primarily based, on savings rather than taxation. That this is where the money for the cost sharing comes from. That the state still has to pay a certain amount, but rather than collecting a full amount in taxation, try to keep a certain amount of the money with the individual so that they're making the decision. You achieve risk pooling and social protection through insurance. So it's not all borne by the individual. Clearly there are some healthcare costs that are astronomical, so clearly imposing those on individuals wouldn't be possible. So there still is insurance, but it is only in a very minority of cases. Those healthcare costs that are very large, day-to-day or ongoing or usual healthcare costs, are generally covered from the medical savings. And then there's the subsidies and sort of equitable distribution of collecting the money used for the subsidies from higher earners. So there still is a role for taxation. So people don't face the full cost, they face part of the cost. So then the rest of the money then does come from taxation. So it's not a complete substitution of savings with taxation, it's just a part substitution. Savings is to sort of instill cost sharing, instill incentives in individuals to get them to consider the costs. There still is a role for taxation.
One is our text number. Donald, good afternoon.
Good afternoon,
A lot of people, apparently there's around 33,000 people in the country on warfarin for a heart condition. Your wife was on warfarin and she was recommended...
No, she wasn't on warfarin. She was diagnosed and the hospital authorities wanted to put her on warfarin.
Okay.
And my family researched what was available, and we discovered that on the 13th of August of this year, a new drug was licensed in Europe. We're 50 years waiting for the replacement of warfarin.
It's called Pradaxa. It's a new wonder drug.
That's it.
And much more effective than warfarin. And what happened?
Well, she met the consultant in Cavan Hospital yesterday week, and he wrote a prescription for the drug, and now we find that she can't get it. So once again, the poor and the old...
She can't get it on a medical card.
...have to pay for the doings of...
Okay. Now, just to be clear, Don, she can't get it on the medical card. She can't get it if she's willing to pay €230 a month.
What does the Constitution say?
Okay, no, I'm just trying to get information out of you.
I understand that, but the Constitution clearly states that it treats all the citizens and children of the state equal.
Okay, and they said they would not, she could not get Pradaxa on the medical card.
Well, that's what I heard you say. I have no proof other than what you have said.
Well, listen to Brian O'Grady. Brian, good afternoon. 51551.
Yeah, no.
Brian, you were on Pradaxa. What happened? Are you okay, Brian? Are you there, Brian?
Yeah, sorry, I'm here, yeah.
Okay, you were on Pradaxa. What happened?
I was on a thing called Nebulis, and I was hospitalised. I went to my doctor, and he sent me into hospital straight away, and they kept me in there. And I was in there for 5 days, and then they said, they changed my medication, and when they were coming out, they were giving me a prescription, and they said, we checked it, you're covered. And they put me on this new drug, Pradaxa.
Right.
And I went to the chemist, I had no problem at all, for 1 month, and then I went back again for renewal. And when they were handing it out to me, they told me that they got a letter from the government to say that this was not covered by any scheme, and that I would have to pay. And when they told me €230, it really upended me altogether.
You'd have to pay for Pradaxa or go back on your old drug. Is that what you're saying?
Well, the doctor, the old drug I was using was not successful. That's why they changed it. You know, and the hospital told me this is the one the most suitable for you.
Yeah, it's getting.
You know, but it's not only the 230, because it's not covered by the any scheme. I pay the prescription charge.
Okay, let me bring Brendan Quinn, and Brendan is a pharmacist in Galway. Brendan, good afternoon.
How you doing, Joe?
Explain this. You're aware of this. I mentioned it there. This decision to take Pradaxa off the medical card.
Yeah, in fact, through your programme, a couple of copies of the documents I've received, as well as a very interesting one that shows that the Scottish NHS have decided to pay for this drug, whereas our own HSE at the moment has decided not to. You can see the economic argument in that. I did a quick check of my own list of patients, and I have somewhere in the region of, last month alone, I saw in the region of 30 warfarin patients, and their total drug bill would have been about €300. And if those patients had been on Pradaxa, that bill would have been closer to €3,000. So there is a big economic challenge to HSE in allowing this drug, but at the same time, if people like the Scottish NHS, who are well known for their ability to refuse a drug if they feel it's not financially viable, if there's not a good reason for using it, they saw fit to allow this drug for the licensed uses, which include fibrillation, which basically means an alteration in the heart rhythm. It's something that puts elderly people at high risk of stroke. So personally, I think it's a very short-sighted decision, and in my experience of 20 years as a practicing pharmacist, it's the first time I've come across a drug being refused completely on economical grounds.
Because it is, I mean, it's not just 10 times the price of warfarin, it's exponentially more expensive.
Yeah, well, again,
I know the argument is, and I'm reading stuff from the New England Journal of Medicine where it's getting rave reviews in comparison to warfarin. But it is much. What is the price difference?
Yeah, it does work out to about 10 times, but you see, it's not that simple because warfarin, the dose varies a lot. Warfarin can't be given to every patient. A lot of patients don't qualify, or it's too risky to give it to them if they're on almost any other medication, but certainly if they're on multiple medications, warfarin's risk increases exponentially. So there are clear-cut cases, particularly in the elderly, where I feel this drug needs to be given, and it's very short-sighted. It's incredibly short-sighted for them to refuse it. So yes, I would be very cautious about overuse of it, Joe, but for this too, that most patients on warfarin have to get their bloods checked regularly. That can be every 2 weeks. So that costs money, and it costs the state money if they have to go into outpatient clinics or into hospitals to get it done. And you have all the additional the time taken up for patients to have to travel. Can you imagine a patient, for example, from Clifton in North Galway having to travel into the hospital?
Okay, that's a good point. Because Pradaxa, if you go on Pradaxa, you don't need the regular blood checks.
That's right. So that's a huge plus for the drug, and that immediately invokes an argument that the costs of the drug aren't all you're looking at, boys. You know, you're not looking at the blood tests or the actual INR testing that goes on, which all involves staff, transport, parking, infrastructure. So I personally think this is shockingly short. At the same time, I understand why we'd be very worried, especially in these straitened times, about too many patients changing too quickly to a drug. And I'm sure you read the piece of facts here about the risks of deaths related to bleeding or overbleeding. So again, you have a drug that's, my argument there is that warfarin can cause the same deaths related to bleeding or overbleeding. So, I mean, those cautions are built into the license, and we all need to be very wary of those.
How much does a month's supply of warfarin cost?
Well, at a dose of about 6 milligrams, off the top of my head, Joe, I'm not standing in front of a computer now, but it's less than €30 would be my estimate.
And a month's supply of Pradaxa?
Month's supply of Pradaxa, 110 milligrams, it's over €200.
Wow. Pat is in Dublin. Pat, good afternoon.
Hello, how are you, Joe?
You were on warfarin.
I was on warfarin.
Why were you on warfarin?
Because I have an irregular heartbeat and I was in danger of stroke.
Okay, and why did they take you off it?
Because I had, every second week you have to go for blood tests, and then you have to wait for the doctor to contact you and tell you then what dosage you have to take for the next 2 weeks, because the dosage keeps changing. So then my cardiologist put me on this Pradaxa, and it was brilliant.
Okay.
Last week I went to my GP and he informed me things had changed, that nothing wrong with the drug I was on. It was a brilliant drug, but that the HSE has now refused to pay on the medical card.
And you're on a medical card?
I'm on a medical card.
Under what criteria? Age, is it? You're over 70? Okay.
Yeah.
So the doctor said, even though you believe Pradaxa was doing better, the doctor prescribed it.
And the doctor had there was nothing about the drug. I went up to my chemist and he said it's a brilliant drug.
And all the clinical trials show
And all the clinical
more
trials
effective.
show that there's been nothing better in the last 6 years has come on the market.
And what do you think of the argument, which I presume is a HSE argument, it could be more than 10 times the cost of
Well, my
warfarin?
argument is, wouldn't you be very frightened going into a HSE hospital now, knowing that you're not going to get the best treatment, you're going to get whatever's the cheapest treatment? I had a friend who was in our local hospital here, I won't name it. He was on Pradaxa, and when his wife said he was on it, he had to bring in his own because the hospital didn't stock it.
And what did you not like about warfarin?
Well, warfarin,
I know you have your fortnightly blood test, which
your
is
fortnightly blood test. I
a lot of
needles, having to go for needles, having to go to the hospital, having to wait, having to have the blood test done, come back, then watch out, and then change my dosage. Now, I don't know whether I was being very careful or not, but I understood, and I could be wrong, that you have to take it around the same time every day. So if you kind of forgot, I would be saying, oh God, I forgot to take,
They say that there will be cost offsets, anticoagulation monitoring, i.e. blood tests will not be necessary, and the rate of clinical events, i.e. I presume incidents, will be reduced.
Yeah.
But still, it's the price. Jeff is in Sligo. Stay there, Pat. Jeff Gorman in Sligo. Jeff, you were on Pradaxa.
I was, Joe. Absolutely brilliant for him.
And what were you on before that, and what was the difference?
I was on morphine before that for the regular heartbeat, and it was a disaster.
Why?
Well, you have to go every Tuesday to get your bloods taken, and it's just terrible what it actually does to your system.
What did it do to your system?
It just messes you up, Joe. It's very, very hard to explain unless you've taken morphine.
Okay.
So I did a regular heartbeat, and lucky enough, we had one of the best doctors in the world over here, Brendan O'Coughlin, over in the Galway Clinic, who cured me of the irregular heartbeat. I got what was known as a PVA, which is a pulmonary vein ablation. That's what that lady that you got. I don't know her name. Was it Eileen?
No, Pat. Did you go, Jeff? Did you go from warfarin onto Pradaxa?
I did, yeah.
No.
No, Jeff. Sorry, go back to the second. Jeff, did you go from warfarin to Pradaxa?
I tell you exactly what happened. My specialist, when he finished doing my PVA, which was my ablation, I said, I do not want to go on to warfarin. So he said, well, I'll put you on Pradaxa, but you have to pay for it. So I went down to the Galway Clinic, and they told me, no, you don't have to pay for it. It's actually on medical card. So I finished with it, and by sheer coincidence, my sister was also on it. She went in to get it, and from the 1st of November, nobody on medical card could get it. Joe, it is, for warfarin, I did my own research, for warfarin, it's 2 pence sterling a tablet. For Pradaxa, is £2 sterling.
So that is much more. That's 100 times the price.
That's correct. You can just check it out online. That's exactly what it is.
And Brendan Quinn, as a pharmacist, would the HSE cover Pradaxa on any medical card, even for a short period?
They will cover it for a short period, for 1 month, because it's often used as a preventer of clotting after a hip or a knee replacement.
Oh, okay.
I just checked an average price there, Joe. It came out at €98 for the 75 milligram Pradaxa and about a tenner for the warfarin. So 10 times is probably more accurate a price difference. And personally, I think.
But given that there's, hang on, Brendan. Given that there's 32,500 people, latest figures, on warfarin.
Absolutely.
If even half of them were to transfer to Pradaxa,
we'd be snookered. Every taxpayer, everyone in the country would be snookered as far as HSE expenses would go. But I mean, you could extend this and start looking at, let's for example, take the top 10 volume of drugs that was.
So they move on then to a discussion of different areas. So this is clearly an issue in Ireland, given the system we have. Like, all those patients there were 100% right, 100% sensible. They were told there was a choice between 2 drugs. One is better than the other. You're the patient, which one do you want? You want the best one. One requires you to get a needle. You're scared of needles. Which one do you want? The one that doesn't require needles. One requires you to go to a hospital every 2 weeks. Which one do you want? The one that doesn't require you to go to a hospital. Does the cost come into your consideration? Not at all. You're facing a 0 cost. So at the end, the pharmacist did conclude that there was a 10 times difference in the cost between those two. So this is like the person driving or walking into the car showroom. Which car are you going to buy? Well, which car is the best? It could be the one that costs 10 times more. Does it offer 10 times the benefit? Well, that's for the individual to decide. In most markets, where the individual chooses for themselves, they weigh up the costs and benefits. In the healthcare market, all the patient will focus on is the benefits. And this is why you get issues like this arising. It is somebody sitting in an office who has made that decision not to offer the more expensive drug. It is not the patients, it's not the doctors, it's not the pharmacists. It's somebody with a fixed, limited budget saying, how do I best spend this money? Somebody's afraid of needles. If someone doesn't want to go to hospital twice a week, I can save, or I could spend millions allowing them not to use needles or not to visit a hospital. But that money could and should be used somewhere else. So you get this conflict emerging between a limited budget of the provider and sort of the unlimited wants of the patient. And this is what emerges. From the patient's perspective, entirely sensible to weigh up one versus the other. But if there was a certain degree of cost sharing involved, so you go to the pharmacy and you say, well, you can have this drug for €10 or this drug for €100? Which one do you want? They could be heavily subsidised, so it could be a difference between €5 and €30, depending on the subsidies and depending on the income. So then the individual would make up their mind. So you'd say, well, you're charging the people for something they should be getting for free. In the Singapore system, they would have the savings. They'd either get that through a reduction in taxation, or if they're not earning enough to pay that amount of taxation, it would be topped up by the state. So the money would still be spent, but it would be under the control of the individual. So where does the money come from in the Singapore system? In Ireland, the payment for the drugs comes from general taxation. So if somebody wants a drug that costs €230 a month, that money must be collected in taxation. So the funding mechanism in Singapore is, first of all, Ministry of Health subsidies. You're rarely charged a full price for something. There's cost sharing and co-payment, but the prices are heavily subsidised. So co-payment is a driver for patient-driven management. So they have what's called the 3M system: MediSave, MediShield, and MediFund. So these are sort of elements that have been added over about the last 25 years or so. MediSave are the medical savings accounts which we look at. MediShield and MediFund. MediShield is to do with insurance, and MediFund is to do with the least well-off, providing a sort of a social welfare blanket. And in time, they've seen that the system does need to be augmented, particularly as people were getting older and living longer. So about the start of the last decade, they introduced the 3 E's. This was savings for long-term care. So that you could build up savings for your more immediate healthcare needs, but it did add in Elder Save, Elder Shield, and Elder Fund, which were for more long-term care. So the financing philosophy of Singapore's healthcare system is based on shared responsibility, coupled with government subsidies to keep basic healthcare affordable. So whatever their equivalent of Liveline is, would be dealing with different issues. It would still have issues involved. I'm not going to fully eliminate the issues, but it does deal with eliminate issues. So the key elements we'll be looking at are the 3 M's: MediSave, MediShield, and MediFund. So MediSave is a compulsory savings scheme. MediShield is a catastrophic insurance that you might need on a very irregular basis, or none, as the case would be for many. And then MediFund is sort of the social welfare safety net, that if maybe people don't have the savings built up, haven't had the opportunity to build them up, or have spent them on other healthcare needs, that there is somewhere else they can turn to. And MediFund provides funds for those who don't have the savings built up. So in the Singapore system, we look at the links between the individuals and the healthcare providers. Going from the healthcare providers to the individuals, clearly we want the healthcare services. Be it visiting consultants, visiting GPs, stays in hospital, getting prescriptions, paying for medicines, whatever it might be. The healthcare providers have that, and we need to get that from them up to the individuals. Going in the opposite direction, we need money. We need the individuals paying and providing for the healthcare providers. And there's different systems in which the money can flow from individuals to the healthcare providers. This is what happens in Ireland. There are 3 avenues in which money goes from people to healthcare professionals. One, you can pay them directly. Direct payment and co-payment. So go to the GP, €50. Go to the chemist, pay for the medicines. There's also minor co-payments for those on medical cards, and a suggestion maybe of a €50 payment, lump sum payment on the upcoming budget. But you can pay directly. Go to a consultant, pay them 90, 120, €150, whatever it is they're charging per consultation. So the money goes directly from the pocket of the individuals down to the healthcare provider, and the services flow in the opposite direction. You could go and purchase private health insurance from the pocket of the individual, pay an insurance premium to the VHI, to Quinn, to Vivas, etc. And then if you have healthcare needs, the healthcare provider again provides you with the service, but the money comes from the insurer. There's a claims payment from the insurance company to the healthcare provider. So the money is essentially going from the individuals to the healthcare providers, but there is a pooling mechanism in between, that being the insurance company. So the money again is flowing down. The third method, and where most of the money in Ireland comes from, is through taxation. So the government collects tax from individuals, and there's no real specific tax for healthcare services. Up to last year, we did have a health levy that was levied on income, and that went directly to the Department of Health and the HSE. But the health levy was abolished with the introduction of the universal social charge. So now all the funding for the tax funding for healthcare comes from the general tax pool. Income tax, VAT, excise duty, corporation tax, CGT, CAT, stamp duty, and capital acquisitions tax. So all the taxes pooled together, and a certain portion of that is gathered by the government and forms public expenditure on healthcare. So this sums up to a huge amount of money in Ireland. But again, it's coming from the individuals. In this instance, the pooling mechanism in the government, and the government decides how much is spent. The issue from an Irish perspective is that between the individual and the healthcare providers, there is a sort of a body or a group. The insurance company decide what they're paying for. Maybe an insurance company wouldn't pay for Prodaxa or whatever it's called. The government decides what they're paying for. And clearly they've decided not to pay for Prodaxa and want people to be on warfarin or whatever the alternative was. So the payment isn't going directly, since the decisions aren't going directly. We'll assume he stopped. So the payments go from the individual to the healthcare provider, but there is sort of a buffer in between. And this is a lot of the problem in the Irish healthcare system. So what does the Singapore system add? Well, it keeps those three methods in place. You still have direct payment and co-payment, money coming directly out of your pocket to the healthcare providers. There still is the tax finance element. It doesn't eliminate public expenditure. And there still is insurance, and there is private insurance outside of the 3Ms that you could go to buy and purchase private insurance. So what the Singapore system puts in place is something in between, again, the individuals and the healthcare providers. But in this instance, it's the medical savings accounts. So the contribution to the CPF. The CPF is the Central Provident Fund, and we'll come to look at that in a bit more detail. It's where the individuals are required to put money into particular accounts. And one of those accounts is the MediSave account. Put money aside for your own healthcare needs. So a certain proportion of income goes into the MediSave accounts. And from that then, the person can make a direct payment to a healthcare provider. So the person can make a payment from their MediSave account for healthcare services. You can also choose to purchase MediShield with the money in your medical savings account. So the catastrophic insurance is purchased from your medical savings account. One issue that we'll note at the medical savings account is you put your money in here on gross earnings. This is all tax-free saving. So in Ireland it would be equivalent like to pension saving. That your money is put into this and then you're taxed. So if you're earning 100 and putting 20 into your medical savings account, you're not taxed on 100, you're taxed on 80. If the tax rate was 50% and you were taxed on everything, you'd be paying a tax of 50. Because you put 20 into your medical savings account, you're only taxed on 80, so you pay a tax bill of 40. So instead of having a lump sum tax of 50 and then having to save, you pay a tax of 40 and you save the other 20 in your medical savings account. So it is attractive for individuals to put the money in. So you can use that then to purchase the catastrophic health insurance. And this will also make a payment to healthcare providers. But this happens in very limited cases. In general, most of your day-to-day healthcare needs come from your medical savings accounts or even direct payments out of your pocket rather than dipping into your medical savings. And then the final avenue the government adds in Singapore is this MediFund, where people perhaps don't have the savings built up or have them fully exhausted. Where do they turn to? If they don't have sufficient income, are they just left high and dry? Well, the state has set up MediFund. So the government from tax revenue injects money into this MediFund. And this is a fund that builds up through time, and the earnings from that fund then are used to pay for healthcare of individuals. So the Singapore system doesn't subtract anything from the Irish system. There still is direct payment, there still is tax-funded public healthcare, and there still is the potential to get private health insurance. What it adds are the 3 M's: MediSave, MediShield, and Medifund. And the difference isn't that substantial. Where the money comes from in Singapore isn't all this Medifund, or sorry, Medisave, the medical savings account. That only makes up 8% of the total amount of healthcare spending in Singapore. The issue is that it introduces cost sharing, that you might only be covering a portion of the cost, but you have to weigh up the costs and benefits. Government subsidies make up 25%, out-of-pocket payments make up 25%, employer payments make up the bulk, either employers spending the money directly on their employees, contributing to insurance companies for their employees, or running their own medical services. Private insurance is about 5%, and the catastrophic insurance is about 2%. So what is this Central Provident Fund? And we'll see that it expands a bit beyond just simple healthcare. So the Central Provident Fund has money coming in from earnings. So it is like a tax. It's compulsory. You must put money into it. So employers contribute and employees contribute. In Ireland, it would be equivalent to PRSI. If you are employed by a firm, they will pay PRSI because they've hired you. Pay-related social insurance. But in Ireland, this goes into a general fund called the Social Insurance Fund. And that's for insurance for disability, for loss of earnings. It pays for pensions, etc. So PRSI goes to fund a huge range of payments in Ireland. But the money is aggregated. It's all pumped into this total fund. And the Social Insurance Fund in Ireland could have 7, 8, 9 billion flowing into it each year, and 7, 8, 9 billion flowing out in payments each year. But those who are making the payments into the fund and those who are getting the payments from the fund are different. Employees in Ireland also pay PRSI. It is at a reduced rate. Employer PRSI is around 10% of what you pay your employee. They have to make that. Employees PRSI is a bit lower. It used to have a ceiling on it, that's since been listed. So both employers and employees are making payments into the Central Provident Fund. The issue here is that each individual has their own account. The Central Provident Fund isn't like the Social Insurance Fund. All the payments aren't aggregated, they're actually kept individual. Whatever money a person pays in goes into their own individual accounts. So there are accounts across 3 areas. There's the Medisave accounts, which we've looked at. There's the ordinary accounts, and there's the special accounts. And in terms of what they pay for, so as we've seen, the Medisave accounts pays for medical expenses and can also buy the MediShield insurance. The ordinary accounts, so this is tax-free saving. This is basically putting money in on deposit, earning a return, but before you ever pay tax, you can use this to pay for housing. Save for a deposit on a house purchase, or in Singapore more likely, an apartment. You can use it to pay for insurance, health insurance, life insurance, other types of insurance. You can use these tax-free savings to pay for third-level education, which isn't free in Singapore. And you can also use the money you put into the ordinary accounts for approved investments. You can buy investments in shares, investment in commodities, investments in bonds. So it does instill belief in savings in the community, that funding for certain levels of expenditure will come from savings, not necessarily from borrowing. And the special account is retirement savings. While you have generally access to the medical and ordinary accounts throughout your life, you don't have access to the special account until retirement. So it's saving a proportion of your income through for 40 years. So it's a compulsory pension saving. In Ireland we have voluntary pension savings, and a huge proportion of the population isn't covered with a private pension. There is the state pension, €230 per week as it stands. But is the state pension going to be there in 40 years' time? Will it be at the same level? Would you be able to claim €230 per week from the state just for being here? Not from working, not from earning. So in Ireland there are those who have their own private pensions, be it in the public sector, where again there is public sector pensions that tend to be quite generous, or in the private sector, where the pension is again based on savings. How much do you put in? But again, the value of those has been questioned again if you're watching the George Lee show a couple of weeks ago. But this is compulsory. Just like PRSI is compulsory, contributing to the Central Provident Fund is compulsory. So how much do you put in? How much of your earnings goes into the Central Provident Fund and then into your individual accounts. Well, when you're quite young, the contribution starts off at its highest amount. It's about 1/3 of gross salary. So in Ireland, this could be considered that you'll be paying 1/3 or more of gross salary in taxation. In Singapore, they do take the money off you, but they put it into your own account. But it is made up of 14.5% from the employer and 20% from the employee. So about 2/5 of the contribution comes from the employer, 20% comes as a deduction from the person's wage. So in Ireland, the PRSI for the employer is about 10%. It's not hugely different. Tax would be far higher. You'd be paying 35% tax in your gross earnings. There is tax in Singapore, but it is much lower because a lot of the funds are angled through this source here. So the total contribution to wage is 34.5%. 23% into the ordinary account for housing, investment, education, insurance. 5% into the special account for retirement, and 6.5% into the medical savings account. So 6.5% of gross salary into the medical savings account. These weightings change as you get towards 50. A smaller amount into the ordinary account, maybe this person has bought a house, has funded maybe the children to third level education, and a greater amount into the special account for retirement to build up the funds necessary to sustain them in retirement. And this is up to age 55. And then once you get to 55, in fact, the total contribution begins to decline as you need a smaller amount in your ordinary account. In fact, what you want to see is the amount you've saved in the special account growing, earning interest, earning a return. And as you get older, your healthcare needs may get increased. So there is more money going into the medical savings account from 6.5% up to 9%. And the view is that as somebody ages, their income tends to increase. So 6.5% of their income early in their career might be a certain amount. 8.5%, 9% of their income towards the latter end of their career will generally be a higher amount. So the percentage is increasing and the amount is increasing. This is enforced on the very poor. Contribution rates start at 0 for wages of 500 Singapore dollars per month. That's about €250 per month, which is quite low. And then rise gradually until wages hit 1,500 Singapore dollars per month, up to about €750. So if somebody is earning less than €750, they don't make the full payments. Clearly savings wouldn't be a priority for them. Just meeting their day-to-day survival needs would be more important. So for a particular limit, you don't have these thresholds. And then the maximum contribution is based on a salary of 4,500 Singapore dollars per month. Because this is tax-free savings, clearly it offers more benefits to those who earn more and pay more tax. That if you're earning a huge amount and can cut your tax bill by 20-25%, the more you're earning, the more you can save. So the savings are limited. So in Ireland, pension contributions can be made for an unlimited amount. And there is suggestion that should be capped, because those who earn more can benefit more. So in Singapore, it is capped. If anything below the required threshold is met, the order in which the money goes into the accounts is the medical savings account is first. If you don't meet the full contribution, the special account for retirement is next, and then the ordinary account is last. So the priority is the health savings account first for your healthcare needs, the ordinary account for retirement, the special account for retirement, and then the ordinary account. So how do they, in a sense, incorporate this Central Provident Fund? And we look at an example of how the CPF works into their health system. So MediSave, MediShield, and MediFund. So MediSave was first introduced in 1984 as an extension of the Central Provident Fund. The Central Provident Fund was set up in the 1960s, but was primarily set up for retirement savings. Since then it's been adopted and added to and augmented as time has gone on. In the 80s they said, well, why don't we use this for healthcare? So MediSave represents about 6 to 8% of wages depending on age, allocated from the individual's Central Provident Fund account. So in anticipation of hospitalisation and acute care medical expenditures later in life. So you need to stay in hospital, you might need a certain amount of money. Where does that money come from? It comes from your medical savings account. So there is an element of risk pooling among family members as it can be shared. So you can use your medical savings account to pay for the bills of your spouse, children, siblings or parents. So the advantage of a health insurance is that it pools risks. It collects premiums from a group of people and only makes payments based on those who need it. With the medical savings account, it's all individual. There is no risk pooling. The risk all stays with the individual. So if they have to make payments, they may not have sufficient funds. But you can have sharing across relations. So one needs to contribute to the savings account up to the maximum limit, which is currently about 30,000 Singapore dollars. So if you're below that, you need to put in the money in. So once you hit the 30,500 limit, and the limit is increased each year based on inflation and what medical prices are, once you reach that limit, they say, look, you have enough money in your medical savings account. There's no point putting 40, 50, 60,000 into this account. You're not going to need it. After that, any excess is put into the ordinary account, which again you can choose to spend on housing, education, insurance, or investment, whatever it might be. So again, the incentive is to continually save. And at retirement, an individual who is above a certain minimum can withdraw the excess amount. So once you get to 65, if you have 25,500 in it or more, you can take out whatever is above that. So again, if you have saved the money through your working life, you then get taken out and spend it as you wish. There are no stipulations on that, but any amount below 25,500 must be spent on medical services. And then once somebody dies, any unspent balance can be passed to their beneficiary. So in your will, you declare who's getting the funds. So it's just like savings you'd have built up in your account, and you just have it in your will about where the funds go, be it a spouse, next of kin, a sibling, whatever it might be, offspring. When looking at how much money is in these accounts, so this is data up to 2006. There are two elements here. On the left-hand side, we have the total savings. So they had reached about 37 billion by 2006. So 22 billion in 2000. Savings each year up to 37 billion. And then on the right-hand side, you have the average balance in each account. So that has risen from about 12,000, maybe up to about 14,000. So these balances have been increasing. So clearly people would have been using these savings accounts, but the amount of savings has been increasing. So they have about a fund of 37 billion across everybody. A pooled fund of everybody. So that's nearly 20 billion euro in a fund built up. And that fund is generating a return. That money is on deposit. That money is earning interest. So it was earning a 5% rate of interest. If nothing happened, it would be increasing by about 2 billion per annum. About €1 billion just from having these savings built up. So you can see the average balancing increasing. However, just because the average balance is increasing, you must take into account where people are in the life cycle. And this is what happens to the funds in your medical savings account. This will be the general pattern for most individuals. So the average was around 14,000. But this differs hugely by age. For those less than 20 or only just after starting working, the average balance was 180. Between 20 and 30 that started saving, up to 4,500. 30 to 40 progressing their career, earnings picking up, the contribution to the medical savings account picking up to 16,800. 40 to 50, it peaks at an average of about 20,000 Singapore dollars. So the rate of increase begins to ease off. Maybe it's between 40 and 50, people's healthcare needs begin to pick up, but the amount they're saving is still exceeding their contributions. So the balance grows. It's only really from about age 55 onwards that the balance begins to decline. So here the amount of contribution is now outweighed by the withdrawals each year, whatever healthcare services they're using. And it drops from 20,000 down to 3,000. The problem Singapore faced that lots of people were living beyond 80 and that older people were requiring long-term care and that they had very small amounts of savings left at that level. So that's why they introduced the 3 E's, Elder Save, Elder Shield and Elder Fund. But this is the general pattern of the balances in the individual's accounts. So what are the advantages of these medical savings accounts? Are they useful? Can they work in the Singapore system? And what happens? Well, one, it avoids intergenerational transfers due to population aging. If the population is growing older, they bring their savings with them. In Ireland, we have a situation where the current generation pays for the previous generation. So people working now are paying for the healthcare needs of those who are old now. That's not so bad when maybe the 20% of the population are dependent over 65. But as the demographics change and it goes to 30 or 40%, suddenly the amount of people working for everybody who's dependent is falling dramatically. So now we could have 5 people working for every 1 person over the age of 65. In 30 or 40 years' time, we might have 2 people working for every person over the age of 65. So you have to collect sufficient tax then from those 2 people to pay for the dependents, whereas now you have to collect sufficient tax from 5 people. But this avoids this intergenerational transfer, as each generation brings their savings with them. If there's more people in a particular generation, there's more savings. They each have their own account, so the money flows with them. It contributes to further growth and sustainability. It represents investment instead of consumption. So in the health accounts alone, Singapore has 37 billion saved. If you look at their position in net debt, in regards to how much they've borrowed, they have huge savings. In an Irish situation, we're looking at huge household, government and corporate debt. We simply didn't have the savings built up when the money was there. The mantra of Charlie McCreevy, when I have it, I'll spend it. Households borrowing to excess. It promotes personal accountability and family responsibility and individual choice. Rather than going to blame somebody else, the first port of call is the individual. The medical savings account have demand-side incentives to contain costs. You want the drug that's 10 times more expensive, well, you're going to have to pay a bit more. You mightn't have to pay 10 times more, but if you want the extra drug, if you don't want the needles, don't want the test, don't want to go to a hospital, you will have to pay a bit more. So it's a matter of weighing up the costs and benefits. The decision isn't being made by somebody in an office. It mobilises additional extra budgetary resources. If the government doesn't have the funds, well, then the individuals have it themselves. It enhances portability and employment mobility. Your savings stick with you. It's not a case of one employer offers better healthcare benefits than another. They both track, the savings track the individual. You move job, you bring your account with you. It supports appropriate pricing of fees and cost recovery. The government gets to set the prices. It allows for backup insurance and enhanced protection. People can pay for the catastrophic insurance. And it facilitates competition. It's your money. You choose what hospital to go to. You choose what doctor to go to. You choose what chemist to go to. So we'll leave it at that for today. And we'll take it up with the rest of the Singapore system next Thursday. Again, no class tomorrow.